Thank you for allowing me to come here today to talk about our research collaboration, which is an European collaboration and it's called AutoCure, coming from curing of autoimmune diseases. And my name is Anka Katrina. I'm a rheumatologist and a scientist at Karolinska Institute in Stockholm, and I am here today on behalf of Lars Klareskog, the coordinator of the whole program, and the rest of the executive group of AutoCure. As said, this collaboration is a pan-European collaboration and effort to promote translational research within inflammatory rheumatic diseases, especially rheumatoid arthritis, but not only. And has Euler as a partner, started on 2006, will end in 2011, and it's founded by an FP6 European program. And talking about curing autoimmune disease is it's, as said, not an easy topic. Is it possible to cure autoimmune disease? And I would say that the first hope that this might be possible in the future came already in the early 2000s with the early studies where anti-TNF or TNF blockade therapy was used in the first patients with rheumatoid arthritis by Professor Mark Feldman and Sir Ravinder Maini at the Kennedy Institute in London. Later on, several other European groups have extended and have performed pivotal clinical studies in treating patients with rheumatoid arthritis with the same type of agents. And afterwards, further international collaboration have finally changed the paradigm of treatment of rheumatoid arthritis by introduction of several other treatments that are highly effective for treatment of rheumatoid arthritis. But despite so great progress in the therapy, despite the high efficacy of these agents already in 2000, when someone wanted to know more about what is really behind rheumatoid arthritis, how this disease appears, despite great knowledge we did not have so much information about what's really happening. We knew that it's a chronic disease. We knew that it starts most probably very early on the life by the complex interaction between genes and the environment that leads to activation of the immune system, that finally leads to inflammation, mainly into the joints or in other parts of the body, like muscles, that will finally lead to the pathological inflammation process that leads to destruction. And it is not only that, it's a lot of other things that might happen, a lot of other diseases and comorbidities that make rheumatoid arthritis a very heterogeneous disease. But when looking into our basic book, the primer book on rheumatology on 2001, when we were treating our patients also successful, we read that the inflammation develops in a genetically predisposed host. Exogenous agents that precipitate disease have not been identified. And this was the challenge of AutoCure. And based on this, we have made our strategy, and this is based on using molecular immunology to investigate and finally to interfere with specific immune reaction in each individual in order to treat or to cure autoimmune diseases. And this is just a try to put on the view of rheumatoid arthritis as it was already at the beginning of AutoCure. We know, I said already, that rheumatoid arthritis, like many other chronic inflammatory disease, is a very heterogeneous disease. We have different kind of clinical pictures, we have different kind of responses to treatment and so on. And we believed then that specific interaction between certain genes and certain environmental factors will lead to a certain type of immune reaction that will define a certain type of immunophenotype of disease, a certain type of rheumatoid arthritis that can have distinct clinical phenotypes. For example, more or less destruction, more or less complication in terms of other diseases and so on. And we aimed to study the complex interaction between environmental stimuli, immune events, and genetic in order to be able to better understand and then to maybe interfere with a specific immune process in each individual. And AutoCure has largely contributed to the new view on the etiology of rheumatoid arthritis. It's the same longitudinal view, but some more pieces of the puzzles are there. We know today that smoking is inducing changes into the bodies we call it citrullination. It's a change of the molecule that exists inside of the body, for example, into the lungs, and they are here represented by the red dots. And these changes leads to a change in the endogenous molecules that will be recognized by the immune system, and the immune system will be activated, will lead to production of autoantibodies, and these autoantibodies will further promote clinical and chronic inflammation into the joint that might lead to bone destruction. And just to show some of the results that are result of the autocure collaboration. Here it's just an example on how we have investigated the influence of the smoking on the development and the treatment of rheumatoid arthritis. In the upper panel, you have on the left side cells that are coming from the lungs of a healthy individual, that it's a smoker. On the right panel, cells that are coming from a healthy individual that is not smoking. It's an obvious difference. One is blue, the other one has no blue. That is just to exemplify that if you are smoking, you are going to have changes in your cells that are this modification that I was talking about, the citrullination protein. While if you are not smoking, you will not have these changes. But does this experimental observation has any relevance when we are thinking about our patients? And then we went from a basic research to an epidemiological type of question. And because of the collaboration, we were able to have large cohorts of patients. And we asked the question, is it so that smoking is making any difference? Smoking, of course, together with this modification that I am talking about, the citrullination of proteins. And what we have done then? We divided the patient in patients having this kind of immunity against citrullinated proteins, and patients that do not have this immunity. And then we looked on the influence of the genes and the environment, the smoking, on development of this kind of diseases. And again, you see there are two completely different pictures, two completely different graphs. On the left panel, what it is shown is that if you are a smoker, if you are a smoker and you have a specific genetic background, you have a 20 times increased risk of developing rheumatoid arthritis as if you are no smoker and not having the genetic background. What's happening, but this is true when you have this kind of immunity in rheumatoid arthritis, immunity against citrullinated protein. If you lack that immunity, so you have another kind of disease, another phenotype of disease, this influence is gone. Smoking is not does not play any role anymore. Most probably, we will have to look for other genes, and we will have to look for other environmental factors that will make this picture to move to the right. Is that just for classification? Because then it will not be so important just to